Okay, so first of all, UKMEC. What does UKMEC means? UKMEC means the category 1 to 4. It tells you the definition of category is tells you about which contraception is safe for which condition. So category 1 is perfectly all right, perfectly safe. Category 2 has some issue, but only minor issue, only theoretical risk. So you can prescribe category 2 also. But the main problem in exam is if they give you both category 1 and 2 contraceptive options, then you should choose category 1. So that's how sometimes they confuse you, which is the most difficult part to remember, which are category 1 and which are category 2, because ultimately both are safe and both can be prescribed easily. So here is the catch. Then category 3 means risk is more than the benefit. So definitely you should choose. And category 4 means you don't want to prescribe because means danger. You might take a risk, but that is all consultant call, not your call. So don't worry about that. That is just for the higher and advanced things. For our exam, for exam purpose, cat and 4 you are not going to choose in the exam. This you cannot give to a person, and 1 or 2 are the one you are going to give to any person. If in options you have one or both, you will be choosing one. Sometimes they might ask you which of the following is category 3 for some particular contraception. So for that, keep a note of category 3. Otherwise, both 3 and 4 are not going to be used for that particular situation, because there are many contraceptive options and always you can find a safest one. You can find a category 1 or 2 for that particular situation. Importance of categories, which you have to remember for some particular specific things which are commonly asked in the exam. Okay, so if you see here, these are all the short form: copper IUD, LNGIUS means Mirena, IMP means Implanon, DMPA is DMPA injection, the progesterone injection, and POP is progesterone only pill. CHC is combined hormonal contraceptive. Why CHC and not COC? Because CHC can be patches, can be ring, can be pills, anything. So CHC means combined estrogen plus progesterone. I will be initiation and C will be continuation. If you see sometimes continuation is allowed, but things are that. So that initiation is not advised. Sometimes the thing that's why I and C are important. We will discuss further how continuation are allowed but initiation cannot be done. So this is the property sometime the importance of I and C. Now, if you see, any contraception can be used for any age. There is no age bar. If you see, there is no category 3 or 4. If you see, all are category 1 or 2. It can be used for any particular age, isn't it? So any contraception. So what kind of question they are going to ask you from age? Because they do ask in the exam commonly. So if you see, some are category 2 for some particular age. Like if you see less than 20, the IUCD like copper IUD or Mirena is category 2. If in your practical practice also, if you see, for a young woman, you don't prefer copper IUD, isn't it? You don't prefer because you feel it is difficult, it is uncomfortable for her like that. It's not like you cannot give it. Yes, you can, even for emergency contraception, you can always give copper IUD, and that will be your choice even in less than 20 for emergency contraception. Copper will be your first choice. So you can give because 2 can be used easily, but if they will ask you in less than 20 which to choose, then you will not preferred copper and LNG over Implanon, which is category 1. So this is the crux. This is how they make the question. That in less than 20, which is your preferred contraception. So these two are out. Less than 18, DMPA is out because of the osteoporosis. So you are left with a choice. These are the three higher Implanon, which is category 1 after menarche and perfectly safe and very good one. And the most effective one also. So very important this point. And then comes the POP, which is oral progesterone, which is a good choice, which is category 1. But if you ask me, either I will choose Implanon or POP, you will choose Implanon over POP because this is most effective, the least failure rate. So this is how you have to choose. Always you have to choose the most effective one, longer acting one, which is also known as LARC, longer acting contraception, over the short one. POP, they have to take daily, maybe young girl, they might forget taking everyday pill. So failure rate will be more for POP for them. And anyways, Implanon is most effective. And for young girl, you don't want them to become pregnant. So you want to give the most effective contraception. So this will be your first choice in young girl, though there are one also, but this fulfill all your criteria which you want from any contraception. The most effective one, the least bothering one for the young girl. So this how you make your choice. CHC, yes, you can give for the young girl also, no restriction for that. But usually less than 18, sometimes we don't prefer CHC because estrogen can lead to early closure of epiphysis and the height might be affected. So obviously, in a young girl, if they give you less than 18, your first choice should be Implanon. What extra precaution you have to take for the young girl other than prescribing her Implanon? What advice you will give her? What is your other main concern for young girls' contraception? One is you want to give them most effective,
And the
Barrier
sexual transmitted
so you
diseases,
chose Implanon. What is the other
and
concern?
condoms,
sexually
condoms.
Very
transmitted
good. Sexually
infections.
transmitted.
STI.
Yes, very good. So because there is a risk of STI, because we are worried for their future health, future sexual health, and they are young, sometimes they are unaware of the consequences, so they might not be doing all the precautions. So sometimes in the exam they will give you dual protection like Implanon plus condom, Implanon plus barrier. So that will be the ideal choice for young girl. If that is not there, Implanon plus barrier is not there, you will choose Implanon because that is the most effective one and you want to give them that. So this is about young girl, how to choose a contraception for the young one. What about the old? Is there any precautions for the old? Yes, there is. For old, always remember there are two precautions. One is DMPA and one is CHC. Can anybody tell me why?
TMPA because of risk of osteoporosis, bone loss
Very
of
good.
bone density,
Bone mineral
and
density. Yeah.
Yeah. And CHC,
and CHC
CHC
because of
for
cardiovascular risk.
And
DVT.
VTE also. Yeah.
VTE. Very good. Yes, cardiovascular is there, but mainly you're concerned with age. Cardiovascular, if anybody has, they will have. But if somebody is healthy also, at the age of 40 and more, you don't prefer CHC because there is risk of VTE as the age increases. We get VTE questions sometimes. Family history of VTE in younger than 45, younger than 50, like that. So that is how the age signifies the increased risk of VTE as the age increases, age-related risk. That's why CHC become category 2 for more than 40 and DMPA become category 2 for more than 45. So please remember this. Now we know according to age. In age, you have to remember both 2 and 1 because as I told you, sometimes they like asking this about the age. Now, coming to parity. Parity, there is no problem. Anybody can use anything. So don't think that for a nulliparous I cannot put copper IUCD or Mirena. There is no rule like that. Everybody can use everything. So parity is not a problem. Anyone can use anything. Then comes the breastfeeding. We have already discussed in the postpartum session that for breastfeeding, yes, I will ask you rather than telling you, for breastfeeding women, how long you're not going to use CSC?
Pardon?
And for non-breastfeeding, how long you're not going to use CSC? Because this is the most common question asked in exam.
For
For breastfeeding, how
non-breastfeeding,
long you're not going to
for
use CSC? And for
non-breastfeeding for 2
yes,
years and for breastfeeding for 1 year.
For breastfeeding, 6 weeks, and for
Ah,
non-breastfeeding, 3 weeks.
Weeks. Yeah.
very good. Yes. Breastfeeding 6 weeks. So we are here
6 weeks.
talking about contraindication, though that is not a preferred one. If you see after 6 weeks till 6 months, still it is category 2. But as I told you, category 2 can be prescribed. So that's why they ask you that till how long absolute no no. So absolute no no means category 4 for breastfeeding for CHC is 6 weeks. And for non-breastfeeding, it is 3 weeks. So don't forget it. These are recent recalls that for breastfeeding, how long you are not going to use CSC. So that is what they always like to ask you. Recent recalls that for breastfeeding, how long you are not going to use CSC. So you will choose category 4 means up till 6 weeks for sure you are not going to use. 6 weeks or more, it will become category 2. That is the beauty. That's why. The same way DMPA in the first 6 weeks, it is category 2 because of the spotting things with the DMPA. So remember these things which they always like to ask you. The till how long absolute no no. So remember these things which they always like to ask you because less than 3 weeks breastfeeding your CSC. Now we will go to the next. So as we discussed, the young women implanon is the best. Now if you see, what about age and obesity? So if you see age and obesity, 35 or more and BMI 35 or more, both age and BMI, if they are 35 and more, it's not a good thing. It's not a good thing for CHC. So if you see, if their age is less than 35, no problem. Even if they are smoker, they can use CHC because it is category 3, so you're not going to use CSC. So anybody who is smoking, it is category 2. But if they are smoker and their age increases to 35 or more, then it become category 3, so you're not going to use it. So either they are smoking and either their age is more than equal to 35 or they are using, they have stopped the cigarette less than 1 year. So that is not enough. So if they have stopped less than 1 year or either they are taking more than 15 or less than 15 or whatsoever, ultimately you're not going to give it. So anybody who's smoking, or have smoked less than 1 year, you're not going to use CSC. All other are category 1. So no problem. Only CSC is a contraindication. So why not try something else? So you'll not give. The same way for obesity, there is no contraindication for any contraception regarding obesity. This is a very common question in exam. Sometimes we get confused. Oh, if she's so obese, will Implanon work? Will DMPA work? Yes, it worked perfectly all right. So obesity is not a criteria for any other contraception. Only CHC because of VTE risk. That's why more than equal to 35, you are not going to use CSC. So smoker more than equal to 35 and BMI more than equal to 35, you are not going to use CSC is what you have to remember. Anything related to smoking, anything less than 1 year stop smoking, you are not going to use CSC. So keep it in mind. Now, VT is very favorite always in contraception and always CHC is the main problem for the VTE. So before discussing about VTE category 4 and 3, let us just discuss what comes in our mind to whom we are not going to give CHC. What do you think? When you are not going to give CHC for sure. What do you think? Let us discuss so that you will never forget. Even generally, if somebody asks you, you can easily answer that. So what comes in your mind that when you are not going to give CHC for VTE risk? What do you think?
Those with cardiovascular problems.
Those is previous history of
I'm
VTE or
asking
current
about
VTE.
VTE. Very good. So history of VTE for sure you're not going to give. Current VTE for sure you're not going to give. What else do you think?
Also, when she is
If
at
we have
risk of VTE, like prolonged surgeries, immobilization.
that is her personal problem, isn't it? She is undergoing
Yeah.
for some surgery like hip replacement or something where she is not going to be mobilized for a longer time. So prolonged immobilization is a bad thing. So you will not give her CHC even if she is taking pills, oral contraceptive pills or something. You have to stop before major surgery 1 month prior or 15 days prior. 4 weeks prior, you have to stop. So
From
third is this. Fourth one where it is category 4 is
and
mutation. And the fifth one
thrombophilia.
where,
Thrombophilia.
isn't it? If she's already a known thrombogenic mutation, for sure you are not going to give her CHC,
Yeah.
isn't it? So
Yeah.
yes, so known thrombogenic mutation, which is thrombophilia, or her personal history of major surgery with prolonged immobilization, or history of VT or current VT, you are not going to give them CHC for sure and it becomes category 4, isn't it? So there are 4 category 4. Easy to remember now? Her personal prolonged immobilization, her personal field. Then it becomes category 4. 4 are category 4 and there are 2 category 3. So if you see category 3, then comes the family history of VT in young person less than 45, and then comes the immobility unrelated to surgery, like wheelchair use, debilitating illnesses where like somebody with spinal cord injury or something, they are immobile. Then it becomes category 3. So family history and prolonged immobility unrelated to surgery become category 3. So 4 and all questions of VT you can solve. Family history of relative more than 45, then it is category 2. VTE in first degree relative. So remember the age. Age is very important. Then only it may become category 2 sense. So then it is not a problem. So this you have to keep in mind. The same way, major surgery without prolonged immobilization, like if somebody is undergoing some surgery, like hysterectomy is also a major surgery. If they undergo open hysterectomy, and so then in such situation, so as I told you, every small thing is important, every condition is important. So 4 4 and 2 3 is what you have to keep in mind. So this is all about VTE. Now, if you see, sometimes they ask you varicose vein, superficial venous thrombosis, that are not a problem. Varicose vein is category 1, no problem. Superficial venous thrombosis is category 2, not much a problem. So keep all these silly things also in mind because they confuse you like that. She has varicose vein, so you will think, oh, CSC has a risk with of thrombosis, so why should I give it varicose vein? Yes, in your practical life you might not give, but you have to solve the question here according to UKMEC, and they confuse you like that. So you should remember that varicose vein and superficial thrombosis is not a problem. Minor surgery without immobilization is not anything without immobilization is not a problem for VTE. So this is how you should understand about VTE risk. Now comes the cardiovascular. We all are much aware that cardiovascular thing we don't want to be because again symptoms will show thrombosis. Times will happen, there will be chance of thrombosis like heart failure and all. So even anybody who has multiple risk factor for cardiovascular disease, you will not prefer CHC because there are other option available. Why not give the safer one like non-hormonal like copper? Best. For heart disease, copper is the best. If you see, almost everything is category 1. Can somebody tell me for which heart condition copper iodine is not a good idea?
Prolonged QT interval.
Yes, anyone?
Prolonged
Very good.
QT interval.
Very good. And this is also exam question because whatever you yes, very good, Dr. Gopa. Prolonged QT interval is right because in prolonged QT, copper T become a contraindication, category 3 or 4. So you're not going to give for prolonged QT. So this is the only heart condition where copper is not a good advice. Otherwise, you can always give copper for heart problems. Right? So we always know that yes, if systemic problem, copper is a good idea. So any systemic problem like heart disease and all, you prefer copper. But we discussed the exception. Now, then we think that out of combine and progesterone, which is safe. So progesterone is safer over combine in heart disease. We know that. The combine is the most worst thing in cardiacs. If you see, almost everything is 3 4 like that, except history of BP in pregnancy, which will disappear, known dyslipidemia, which is not a big risk. So CHC is a complete no-no for a cardiac problem, either hypertension or vascular disease or whatsoever. But you have to understand that for some condition, even progesterone is not a good idea in cardiac problem. Though almost for everything it is 1 and 2, but some like DMPA for multiple risk factors and vascular disease, it become category 3. So this you have to keep in mind because though progesterone is safe, but you have to remember all the exceptions. So exception is multiple risk factor for CVD and vascular disease for DMPA. And if you see all the hormones are not a good idea if there is ischemia or stroke. So ischemia or stroke, never ever choose any progesterone, any hormone, nothing, only copper. Because if you see continuation become category 3, category 3 DMPA is also category 3, and even DMPA for vascular disease and multiple risk factors category 3. So this differences you have to remember because this is how they confuse you. If they will give you ischemic heart disease and stroke, you're not going to choose any hormone. You will only choose copper. If they give you specifically vascular disease, means they are diverting your attention towards DMPA. Yes, CSC is a contraindication for sure, but DMPA also is a contraindication if she is vascular disease or multiple risk factor for this CVD. So these exception you have to remember. Then comes the breast. What is your idea about breast? Which hormone is bad for breast? Knowledge, we got knowledge, so breast should be in a better way. What do you think? In breast disease, in breast cancer, or history of breast cancer, or current breast cancer, are you going to give them hormone or no?
No, progesterone is bad.
No, very good. Because if you see, everything is category 4 and 3. If current category 4, if past category 3, so all in all, you're not going to give any hormone for breast cancer. Like for cardiac, you don't prefer hormone for cardiac. The same way, you will not give any hormone for breast cancer for sure. So your only choice is copper. Then how they confuse you? Then they confused you about family history of breast cancer. That is not a problem. Family history is not a problem. Benign breast condition is not a problem. They will give you fibrocystic breast disease. That is not a problem. That is a benign condition. So where everything is category 1. So these are commonly asked questions. Benign breast condition and family history of breast cancer, where everything is all right. Then comes the undiagnosed masses, which is always dangerous. And whenever there is undiagnosed mass, there is a risk of cancer, right? So undiagnosed masses, it will be category 2 and 3. And carrier of mutation BRCA1 and 2, it will be category 3 and 2. CSC always will be one step ahead of progesterone. But all in all, if you see, for these two, no problem. And these two, it becomes 3 and 2. And these definitely complete no-no. So this is how you have to memorize about breast cancer. Always the benign things you always keep in mind because sometimes in back of our mind we think if breast cancer I cannot give, can I give with family history? Maybe it is category 2. So no, it is completely all right for benign breast disease and breast cancer in family. Okay, then comes the migraine. We all know migraine is not a good thing with CHC, isn't it? So any migraine either with or without aura, because with aura become category 4 and without aura become category 3. So all in all, any migraine you are not going to give. Hi, my dear caller one, how are you? Please don't share the class link with anybody. It is a more of an interruption for us and no benefit for anybody. Okay, so for any migraine, you are not going to give either with or without aura because ultimately it will be 4 and 3. So you are not going to give migraine without or with aura. Non-migraine, no problem. You can give anything. If there is history of migraine with aura also, then also. All in all, CHC is a bad choice with migraine is what you have to remember. Then comes the which condition. Then some problem. Progesterone is not a good. So past and present, progesterone is not a good. Same for liver problem also. Sometimes progesterone is not a good idea. So that we have to keep in mind because most of the time we think that whenever we cannot use combined, we can use progesterone. Yes, most of the time it is true, but we have to understand the exception of these things. So if you see cirrhosis, severe cirrhosis, progesterone is also not allowed. Otherwise, no problem. Only for severe cirrhosis, you are not going to use. For cancers, you are not going to use. Otherwise, this hepatitis, cholestasis, gallbladder disease, you can use. So remember these two, cirrhosis and liver tumors, which could be adenoma or which could be carcinoma, where you are not going to use progesterone also. So this you have to remember. The other important thing is pregnancy related hypertension, pregnancy related diabetes, pregnancy related cholestasis. In all these three conditions, you can use oral contraceptive pills. Pregnancy related, you can use because category 2. But past COC related, you are not going to use because, yes, if COC induce cholestasis, definitely you cannot use COC for them. So this is the difference. Sometimes they confuse you with this. So remember this. And all these things, if you see, if symptomatic, then CHC is not a good idea. So these all liver problem where you cannot use progesterone is what your main focus should be. Okay, now what are the bleeding? We all know that there are some contraindication of copper IUD also. Like copper IUD is a good thing for systemic problem, but sometimes it will be a bad thing for local problem like local cancers. If cervical cancer, you're trying cancer, if local infection, if there is any bleeding, undiagnosed pregnancy. So anything local is not a good idea for copper. Like molar pregnancy with high HCG, we already discussed in early pregnancy. So if you see, copper is not a good idea here sometime. Like if the HCG level are high with molar pregnancy, if unexplained bleeding, because unexplained bleeding could be a cancer, so it become category 4. But if you see irregular bleeding, heavy bleeding, prolonged bleeding, and all that, still you can use copper. So definitely you will choose CHC over anything else. So that is where you might think that copper might not be used, but you can use. Only in unexplained you are not going to use. Only in soft uterus like GTD you are not going to use. Otherwise endometriosis, benign ovarian tumor, severe dysmenorrhea, no problem. You can use anything and everything. So most of the time you will see that for benign problems, like benign breast disease, benign ovarian tumor, there is no problem. You can use any kind of contraceptions. Any bleeding problem if you have, always CHC will be your preferred choice over anything else because that will control your bleeding pattern also, isn't it? Irregular pattern, heavy prolonged bleeding. This will treatment of category 1 and all other are category 2. So always choose for any. Sometimes how they make the question. She has irregular bleeding and she has dysmenorrhea and she wants contraception. So what will be your choice? So definitely you will choose CHC over anything else. So that's how they ask you in exam. Severe dysmenorrhea, all these whichever is suppressing ovulation will help with the dysmenorrhea. But copper will not be your good choice. So this is how the simple things sometimes they ask. Otherwise, most of the time they ask you category 3 and 4. Some common scenario they ask for category 1 and 2 like age, like this I told you bleeding problems and dysmenorrhea like things. Okay, now come the IBS. If you see for IBS, no problem, anything can be used, but CHC and POP is category 2. For anemias, if you see copper IUD is category 2. Why? Because there could be heavy bleeding with copper. So for anemia, you won't prefer it over others, but CHC and POP is category 1. So for anemia, you won't prefer it over others, but CHC and POP is category 2. still you can use it. SLE. SLE is always favorite in exam. So SLE, the contraindication come only if there is positive APLA antibody, positive antiphospholipid antibody. If there is no positive antibody, no problem. Anything can be used. Though copper will be preferred for any systemic problem, but still anything can be used. But with positive APLA antibody with SLE, CHC become the category 4, so you cannot use. So anytime positive APLA antibody, you will not use CSE because there will be high risk of ET, isn't it? So that's why this is category 4. All other are also category 2. So if in question, they will ask you, women with SLA with positive antiphospholipid antibody, what will be your first choice, or even without positive antibodies, which is your first choice? So you will prefer copper over anything else because this is category 1, and all other are category 2, and CHC is category 4. So this is how they make the question. This is how the finer detail you have to remember about some things which are their favorite. Now, UKMEC 3 for all progesterone method. Now we saw already all the description, all the finer detail of the chart. Now we will categorize it. We will summarize it all in one page so that we can easily revise it. So UKMEC 3 for all progesterone method, if you see, ischemia, stroke, we discussed already. Breast cancer is not a good thing. Liver problem like syphilis, these are the three things which are things which are category 3. So here you can use now UKMEC is risk factor, you will not start. Now, UKMEC is good. Long term, you will not start. Even asymptomatic, you cannot use cough. You're not going to use it. Then you cannot use. But if it is more than 200, complicated graft failure, immunocompromised, be get an infection, cancer, cervical cancer, endometrial cancer, soft tissue, you cannot use it. So these are all understandable. So you don't have to mug it up. You have to only remember this HIV with CD4 less than 200, and even asymptomatic chlamydia, you are not going to give copper. Then 3 or 4 for we already know from postpartum that 48 hours to 4 weeks you cannot use. So after that, either within 2 days or after 4 weeks, you can use copper postpartum. In sepsis, because of the soft uterus, chance of perforation, GTD, soft uterus, chance of perforation, distorted cavity. Here I want to specify this to you that for distorted cavity means submucosal fibroid. So don't think that intramucosal only submucosal fibroid. So if they give you submucosal means they are telling you not to use copper. If they give you only fibroid, you can easily use it. So keep that in mind. This is how they confuse you in exam. Then comes the pelvic tuberculosis where it become again category 3. So these are all things you should keep in mind. As I told you, broadly to remember is for systemic problem, copper is a good thing. For local problem, copper is not a good thing, like unexplained bleeding, pregnancy, infections, cancer. So these are the things, or soft uteruses like sepsis, molar pregnancy, distorted cavity, local problem, mechanical hindrance. Okay, so if you see just a detail about copper, how I wanted to emphasize about initiation and continuation. So current PID, this is always exam question and they always ask if a woman had PID. Sometimes they will ask you, can you, she's already on copper IUD, she's using copper IUD for contraception and now she's having PID. What to do? What to do? Yes, what to do means continuation is category 2. So no need of removing it, isn't it? You will not start it. This I specifically put because to clear your doubt of in PID how to handle copper. In PID, copper IUD, you can continue if she's already on it. So that's why in PID, the norm is that 3 days you will continue and see if she improve with antibiotic in 3 days, no need of removing copper IUD. If she doesn't improve after 3 days, they say that you should remove because then you don't want to take the risk of further. Any foreign body is a source of infection, isn't it? So you don't want to escalate the problem. So till 3 days you will wait with antibiotic, and if she improve, no need of removing it. But after 3 days you have to remove if she doesn't improve. This is a norm with PID and copper. Other sexual infection, I already told you and summarized that for asymptomatic continuation is a problem. sorry, for asymptomatic also and symptomatic also, initiation is a problem and continuation is all right. So if anybody has any infection, continuation is all right if they are improving with the antibiotic. No need of alarming the thing that immediately remove the copper IOD because she had STD or PID. No need. So this is what you have to keep in mind. That continuation is acceptable if their infection improve with antibiotic. Okay, so this is all about UKMEC. Anybody has any doubt about UKMEC? How to memorize it? What are the important things they ask in exam about UKMEC? Clear, all of you?